So, um, imagine sitting across from a perfectly healthy 32-year-old.
Mm-hmm.
They just received an MRI for like a routine tension headache.
Mm-hmm.
And you have to look them in the eye and explain they have an about 50% chance of developing multiple sclerosis within the next decade.
My goodness, yes. It is a heavy conversation.
There is no limb weakness, no optic neuritis, just a few unexpected white spots on a screen. Suddenly, you are navigating one of the most complex clinical dilemmas in modern neurology.
You really are.
Welcome to the Weekly Neurology Deep Dive, produced by Elmer Givone. Today, we are wading directly into the murky waters of diagnosing and managing patients before they even realize they are sick.
Well, before we unpack the clinical data, I must clearly state that this deep dive is for educational purposes only. There is no commercial goal here.
Absolutely.
This discussion is strictly a summary of the literature, and you, the listener, are highly recommended to read the full paper to capture the complete details for your own clinical practice.
Perfect. So today, we are examining a paper titled Radiologically Isolated Syndrome, a Practical Guide, authored by Audrey Reynolds, Rory O'Donohoe, and Chris McGuigan, published in Practical Neurology in 2026.
Yes.
For the busy neurologists listening who, need the bottom line before clinic starts, could you give us the initial practical summary of this paper?
I certainly can. So, radiologically isolated syndrome is the incidental finding of MRI features of demyelination suggesting multiple sclerosis in a patient with no corresponding clinical symptoms.
Got it.
The 10-year risk of converting to clinical multiple sclerosis is about 50%.
Which is huge.
Exactly. But recent clinical trials demonstrate that disease-modifying therapies significantly delay this clinical onset. Crucially, the updated 2024 McDonald criteria now allow high-risk cases presenting with specific imaging features and unmatched cerebrospinal fluid oligoclonal bands to be reclassified and treated as early or biological multiple sclerosis.
We know what these demyelinating lesions look like,
Huh.
but spotting them in a patient who simply came in for an unrelated issue creates an immediate friction point.
For sure.
The paper notes these incidental findings appear in up to about 4% of MRI brain studies. That is a massive portion of the population walking around with silent lesions.
It is.
But the way we classify this phenomenon has undergone a radical transformation. Because the older diagnostic bar was so high, clinicians were essentially forced to watch and wait while patients potentially accumulated irreversible neurological damage.
And that watchful waiting was deeply frustrating for clinicians. We started with the 2009 Okuda criteria, which demanded a very heavy lesion burden.
My area heavy.
Yes, you needed to fulfill older criteria requiring a high volume of T2 hyperintense lesions in very specific combinations. It practically guaranteed that we were only identifying patients whose brains had already sustained significant widespread demyelination.
Which defeats the purpose of early detection.
Exactly. So the 2018 Magnums and 2023 Consortium criteria attempted to fix this by reducing the sheer number of required lesions. Instead, they placed the emphasis on precise topography.
Meaning specific brain regions.
Yes, requiring at least one lesion in two key regions, like the paraventricular, juxtacortical, infratentorial, or spinal cord areas.
Got it.
The 2023 criteria also integrated cerebrospinal fluid oligoclonal bands into the framework, allowing a diagnosis with fewer brain lesions if spinal cord involvement or unmatched bands were present.
Which logically set the stage for the 2024 McDonald criteria update.
Precisely.
By shifting from a purely clinical diagnosis to a biological approach, we're fundamentally changing the timeline of intervention. Under these new criteria, an asymptomatic patient with typical demyelinating lesions and unmatched cerebrospinal fluid oligoclonal bands is no longer just at risk. They are classified as having early or biological multiple sclerosis.
It moves the entire field from reactive management to proactive intervention. If the biological signature of the disease is present in the cerebrospinal fluid and the imaging, we no longer need to wait for the patient to suffer a debilitating clinical relapse before we intervene.
Well, let us unpack this for a moment. I will play devil's advocate because treating a patient with a completely normal neurological examination purely based on an MRI and a lumbar puncture feels like a massive leap.
It does feel that way to some, yes.
Are we simply treating the smoke alarm instead of the fire?
That is the exact debate that has dominated neurology conferences for the past decade. To resolve it, we have to rethink our definition of asymptomatic by looking at the multiple sclerosis prodrome.
The prodrome.
Yes. Current evidence strongly suggests radiologically isolated syndrome occurs in the latent period between the biological onset of immune pathology and the onset of classical clinical signs.
Wait, so it seems like we have just been looking for the wrong symptoms. If we stop waiting for overt motor or sensory deficits, what are these patients actually experiencing in that 5 to 10-year latent period?
When researchers retroactively examine the medical records of these patients in the 5 to 10 years before a formal diagnosis,
Yeah.
a very clear pattern
What
emerges.
kind of pattern?
They present to their general practitioner with significantly higher frequency than healthy controls, but they are complaining of headaches, severe anxiety, depression, and vague urinary or gastrointestinal disturbances.
Fascinating.
The psychiatric morbidity is particularly striking. The data shows that psychiatric hospitalization is about 200% more likely in the year prior to diagnosis compared to matched controls.
My goodness. That suggests the neuroinflammation is already altering brain networks long before it damages the specific tracts that cause a foot drop or vision loss.
Absolutely.
It makes perfect physiological sense that subtle demyelination or microglial activation in limbic networks would manifest as psychiatric or autonomic dysfunction first.
It really does.
If these nonspecific symptoms are the true early manifestations of the disease, then accurately diagnosing radiologically isolated syndrome is critical.
No.
But we also face a massive risk of misdiagnosis
We do.
because the paper points out that headaches and migraines account for about 29% to about 46% of the MRIs ordered for these patients.
And we must be incredibly careful here. The paper explicitly clarifies that having a migraine as the indication for the MRI does not increase the patient's risk of eventually converting to multiple sclerosis.
So the migraine is just a coincidence.
Yes, migraines are simply the vehicle that gets them into the scanner in the first place.
And migraines, much like small vessel disease, can cause their own white matter lesions. If we are looking at small vessel disease, those lesions typically spare the subcortical U fibers
Correct.
because of their specific vascular supply,
Exact.
whereas demyelination often hits those juxtacortical areas directly. Is that the primary distinction we're looking for when we analyze the MRI?
Yes, that is a huge part of it. Differentiating true demyelination from vascular or migraine mimics requires intense scrutiny of the MRI hallmarks. We are looking for Dawson's fingers.
Which are the ovoid lesions.
Correct. Ovoid lesions oriented perpendicularly to the lateral ventricles. This shape occurs because the demyelination follows the path of the medullary veins.
Makes sense.
And you mentioned the juxtacortical lesions. Those are critical because they actually touch the cortex and involve the subcortical U fibers. Small vessel disease lesions are subcortical. They leave a distinct rim of normal-appearing white matter between the lesion and the cortex.
I see.
Furthermore, small vessel disease usually presents alongside other radiological markers like widened Virchow-Robin spaces, lacunae, and microbleeds.
This is where advanced imaging techniques become essential. The central vein sign is a perfect example.
A fantastic tool.
It is like looking at a river on a satellite map. The demyelination is the flood zone, but susceptibility-weighted imaging lets you see the exact vein that overflowed with inflammatory cells to cause the damage.
That is a highly accurate way to visualize it. The underlying mechanism of a multiple sclerosis plaque is paravenular inflammation. Susceptibility-weighted imaging exploits the magnetic properties of deoxygenated blood, allowing us to see that central linear hypotensity, the actual vein running directly through the core of the demyelinating lesion.
And the diagnostic power of this tool is immense. The paper states that finding more than 6 of these central vein sign positive lesions yields about 95% sensitivity and about 83% specificity for diagnosing radiologically isolated syndrome.
It is incredibly precise.
We also have paramagnetic rim lesions.
Yeah.
From a mechanistic standpoint, these are fascinating because they represent smoldering inflammation.
Exactly.
You are essentially seeing a border of iron-laden macrophages and microglia sitting at the expanding edge of a chronic active lesion.
Precisely. On susceptibility-weighted imaging, these appear as discrete, dark rims that co-localize with the edge of a T2-weighted core. The iron accumulation within those macrophages creates the paramagnetic effect. While their overall sensitivity is low, meaning many patients with true demyelination might not have them sterile, their specificity is exceptionally high.
So if you see one,
If you find even one paramagnetic rim lesion, it heavily points toward multiple sclerosis and steers you away from mimics.
which protects the patient from iatrogenic harm. Mistaking fibromyalgia or migraine lesions for demyelination and starting a patient on potent immunosuppressive disease-modifying therapies is a catastrophic clinical error.
A devastating error, yes.
But here is where it gets really interesting. What happens when the incidental finding isn't so simple? For example, what if the MRI was ordered because the patient had a seizure, Or what if the patient is taking anti-tumor necrosis factor therapies for Crohn's disease?
Seizures introduce a significant gray area. The association between epilepsy and multiple sclerosis is well documented, dating back to the late 19th century.
True.
The incidence of epilepsy in people with multiple sclerosis is 3 to 6 times higher than in the general population. Mechanistically, cortical and juxtacortical demyelinating lesions can become highly epileptogenic.
I see.
Because of this direct causal link, discovering these lesions during a seizure workup is usually considered a manifestation of clinical multiple sclerosis. The seizure itself is the clinical symptom, so we no longer classify it as a radiologically isolated syndrome.
That makes perfect sense. The other complex scenario the paper highlights involves patients taking anti-tumor necrosis factor therapies for conditions like Crohn's disease or rheumatoid arthritis.
Yes.
We know these drugs have an association with demyelination, but the mechanism seems paradoxical. If you are suppressing tumor necrosis factor, which is an inflammatory cytokine, why would that trigger neuroinflammation?
The immunology behind this is incredibly intricate. While the exact mechanisms are still being elucidated, the prevailing theory is that chronic suppression of systemic tumor necrosis factor alters the broader cytokine balance.
Meaning it throws off the immune equilibrium.
Exactly. This suppression likely leads to an unintended proliferation and activation of autoreactive T lymphocytes. These activated T cells then cross the blood-brain barrier, driving anti-myelin inflammation. We still do not know definitively if these drugs initiate de novo demyelination or if they're simply unmasking and exacerbating pre-existing subclinical multiple sclerosis.
That forces an incredibly difficult risk-benefit conversation. You have a patient whose gastrointestinal or joint disease is finally under control, and now you have to collaborate with the rheumatologist or gastroenterologist to decide whether to withdraw the therapy and risk a severe autoimmune flare or continue the therapy and risk further central nervous system demyelination.
It is one of the most challenging multidisciplinary discussions we face. Once we have carefully navigated these mimics and gray areas, and we are confident the patient truly has radiologically isolated syndrome, we must then counsel them on their prognosis.
Let us examine the hard numbers on that conversion risk. The data shows the risk of converting to clinical multiple sclerosis is about 20% at 2 years, about 30% at 5 years, and about 50% at 10 years.
Those numbers are sobering.
They really are. We are telling a completely asymptomatic patient that they essentially have a coin flip's chance of developing clinical disease within a decade.
And that 10-year risk of about 50% is just the baseline. We must apply specific risk multipliers to individualize the prognosis.
Like age.
Yes. Age is a major factor. Being under 37 years old significantly increases the risk, likely because younger immune systems can mount more aggressive inflammatory responses. Male sex is another strong predictor of faster conversion.
The anatomical location of the lesions also matters immensely. Finding lesions in the spinal cord or the infratentorial region drives the risk higher.
Absolutely.
Mechanistically, this is a bottleneck issue. The spinal cord has far less functional reserve than the cerebral hemispheres. A tiny lesion in the frontal lobe might remain clinically silent for years, but that same microscopic lesion in the densely packed ascending or descending tracts of the cervical cord will almost certainly produce noticeable symptoms.
That anatomical bottleneck is exactly why spinal cord lesions are such a prominent red flag. We also look for gadolinium-enhancing lesions, which directly prove there is active blood-brain barrier breakdown and ongoing inflammation at the time of the scan.
Sure.
Finally, the presence of restricted oligoclonal bands in the cerebrospinal fluid indicates a persistent, compartmentalized immune response within the central nervous system.
When you start compounding these risk multipliers, the statistics become alarming.
They really do.
The paper notes that having 4 of these risk factors elevates the 10-year risk of conversion to about 87%.
A staggering figure.
And if a patient fulfills the 2017 criteria for dissemination in space, while also testing positive for cerebrospinal fluid oligoclonal bands, their observed chance of converting to clinical multiple sclerosis hits about 100%. It is essentially a guarantee.
It is.
This brings us to the crucial question. Can we intercept this progression with disease-modifying therapies?
We finally have robust clinical trial data proving that we can. The ARISE trial was a phase 4 study evaluating dimethyl fumarate versus a placebo over a 96-week period. The results were compelling, demonstrating a significant, about 82% reduction in the unadjusted risk of experiencing a clinical event.
Incredible.
One notable observation from the ARISE trial was that every patient who did eventually convert went on to develop relapsing remitting multiple sclerosis.
And the second major trial, the TERRACE trial, evaluated teriflunomide versus placebo in a phase 3 study, also spanning 96 weeks. This trial showed a significant, about 63% reduction in the unadjusted risk.
Yes.
However, it is interesting that about 14% of the converters in the TERRACE trial developed primary progressive multiple sclerosis, whereas ARISE only saw relapsing remitting conversions.
That is an important distinction.
I would imagine that difference comes down to baseline patient characteristics. Were the TERRACE patients simply presenting with more active disease from day one?
Your hypothesis aligns perfectly with the data. The TERRACE trial cohort generally included younger patients, and a higher proportion of them had active gadolinium-enhancing scans at baseline compared to the ARISE cohort.
I see.
That higher baseline inflammatory burden likely drove the increased overall event rate and the progression to more severe disease phenotypes. Both trials, however, definitively prove that early intervention works.
But the clinical reality of administering these drugs is much harder than reading trial results.
Yeah.
There was a third trial discussed in the paper, the CELLO trial, which attempted to evaluate ocrelizumab.
Yes.
But it was terminated because they could only recruit 3 out of their planned 100 patients. Asymptomatic people simply do not want to take potent immunosuppressants.
It is a massive hurdle.
So what does this all mean for the clinicians sitting across from a terrified patient? How do you convince someone who feels perfectly fine to start a heady disease-modifying therapy?
You have to make the invisible damage tangible for them. We discussed the concept of silent neurodegeneration. We know from advanced imaging studies that patients with radiologically isolated syndrome already exhibit dorsal pontine atrophy and subtle cognitive impairments when compared to healthy controls.
So the damage is already happening.
Exactly. The brain tissue is already taking microscopic damage, and the brain's compensatory reserve is actively being depleted. The goal of starting a disease-modifying therapy is to preserve that irreplaceable neural tissue before the clinical threshold is crossed.
It requires shifting their perspective from how they feel today to protecting their brain's physical architecture for 20 years down the line. And the paper suggests that our ability to prove this microscopic damage is about to improve drastically with fluid biomarkers and advanced imaging.
The landscape of biomarkers is advancing rapidly. We are looking closely at serum neurofilament light chain.
Tell us about that.
Neurofilament light is a structural protein found within the cytoskeleton of axons. When demyelination and axonal transection occur, this protein spills into the cerebrospinal fluid and subsequently into the peripheral blood.
Got it.
A simple blood draw can quantify this axonal damage in real time. We are also utilizing glial fibrillar acidic protein, which serves as a marker for astrocyte activation and chronic neuroinflammation.
We also have optical coherence tomography, which allows us to measure the thickness of the retinal nerve fiber layer.
Another phenomenal tool.
Because the retina is essentially an unmyelinated extension of the central nervous system, optical coherence tomography provides a direct, non-invasive window into neurodegeneration.
Yes, it does.
If you can show a hesitant patient that their retinal nerve fiber layer is thinning, or their neurofilament light chain levels are spiking, it transforms an abstract future threat into a concrete, measurable reality that demands immediate treatment.
These tools remove the guesswork. They provide objective biological evidence that the disease is actively causing harm, regardless of how the patient feels subjectively.
Before we conclude, could you provide our listener with that final practical summary to ensure these vital clinical points are solidified?
I would be glad to. Radiologically isolated syndrome is the incidental finding of MRI features of demyelination, typical of multiple sclerosis in a patient without clinical symptoms.
Sure.
The 10-year risk of conversion to clinical disease is about 50%. Recent clinical trials prove that disease-modifying therapies significantly delay this conversion. Furthermore, the 2024 McDonald criteria update now reclassifies high-risk individuals with specific imaging and unmatched cerebrospinal fluid oligoclonal bands as having early or biological multiple sclerosis.
Which profoundly changes how we manage these patients in the clinic.
Absolutely.
As we integrate serum neurofilament light chain, glial fibrillar acidic protein, and optical coherence tomography into our routine clinical workflows, I want to leave you with a forward-looking thought. Will the term radiologically isolated syndrome completely disappear from our vocabulary. We are rapidly approaching an era where multiple sclerosis is staged purely biologically, much like certain cancers, years before a patient ever notices a single neurological symptom. We will no longer be waiting for the clinical earthquake. We will be stopping the tectonic shifts before they even register.
The initial MRI might never be perfectly clear, but our biological precision is finally catching up to the pathology.
Thank you for joining us on this deep dive. We encourage you to apply these insights directly to your daily clinical practice, and we look forward to exploring the next frontier of neurology with you soon.